Hello, my name is Abdulrahman Nimeri, and it is my pleasure and great privilege to be with you today um, in the inaugural course of ERCAT India. And I want to thank Professor Mohit Bhandari for the invitation. I'm going to speak to you today about the different limb length and their value in Roux-en-Y gastric bypass. So the small bowel length is variable, and what I'm going to talk to you today is that if you make the same Roux limb and the same biliopancreatic limb length in Roux-en-Y gastric bypass, you'll have different outcomes because the length of the common channel and the total elementary limb length will be different. In addition, there is enough literature now to show that procedures that have better outcomes like OAGB, DS, SADI, and type 1 distalization of Roux-en-Y gastric bypass all have a longer biliopancreatic limb in common. And I want to talk to you today about that lengthening the biliopancreatic limb is not a panacea. And if you make it too long, you might have issues with protein nutritional deficiencies, and touch briefly about the importance of pouch size in Roux-en-Y gastric bypass. This is my disclosure slide. It has no bearing on the presentation. We have come full circle when we compare the history of metabolic and bariatric surgery. On the left, gastric bypass used to be done in a loop fashion. It went through a long period of Roux-en-Y configuration, and now it is done in a loop fashion, namely one anastomosis gastric bypass. And on the right, biliopancreatic diversion was originally a loop procedure. Then it became Roux-en-Y duodenal switch, or BPD, and then now SADI is a loop configuration of duodenal switch, or BPD. And in any bypass you do, you have to test the assumption you have in your mind about the patient's small bowel length. Most patients have a small bowel length of around 7 meters, but it could be as short as 350 centimeters, it could be as long as 1050. And age doesn't correlate, but the patient's sex and maybe the patient's height correlates. So when you finish a Roux-en-Y gastric bypass, you're assuming that you have enough common channel. You've got to test that assumption. And because of the variability of the small bowel length, whenever we do Roux-en-Y gastric bypass or one anastomosis gastric bypass on the left, because we only measure the Roux limb and BP limb, we actually leave a variable common channel. And on the right side, whenever we do either SADI or DS, because we don't measure the BP limb, we leave a variable biliopancreatic limb. So if we make the same limb length, whether in gastric bypass or in DS, we will end up with different outcomes because we leave the common channel unknown in gastric bypass, and we leave the biliopancreatic limb unknown in duodenal switch and SADI. So what's the importance of the biliopancreatic limb? And as I told you, OAGB, DS, SADI, and type 1 distalization all have in common a long biliopancreatic limb. This is a complex slide that I'm going to take you through, and I'm going to try to test the assumption of the small bowel length. So let's say someone has the average small bowel length of 7 meters. If you focus on their biliopancreatic limb, it is longer in BPD on the left, DS, SADI in the middle, and shorter in Roux-en-Y on the right, and a little longer in OAGB. So the outcomes of weight loss could be explained by the length of the biliopancreatic limb. And if you look at the total alimentary limb length, if the person has average small bowel, their total alimentary limb length is 250 to 300 in BPD, DS, and SADI, but it's much longer in OAGB and way longer in Roux-en-Y gastric bypass. Now, if you change one thing, which is that assumption, and now the small bowel length is 500, you'll notice that the biliopancreatic limb changes, but still BPD, DS, and SADI have longer biliopancreatic limb, but now OAGB is as effective as these procedures, and that explains variability in outcomes. And you notice that the total alimentary limb length does not change in BPD, DS, and SODI, but as your bowel becomes shorter, the total alimentary limb length becomes shorter in OAGB and Roux. And you can imagine what happens if you make the small bowel length 900 centimeters. So again, the BPLM is still longer in BPD, DS, and SODI, but now the total alimentary limb length in the third row is very different than maybe these patients might have significant recurrent weight gain if they have OAGB or Roux. That's why the length of the bowel is an assumption that needs to be tested. And there's been literature to support that a longer biliopancreatic limb leads to more weight loss. So this is a systematic review of 13 studies showing that weight loss is superior in a longer biliopancreatic limb. Similarly, studies have shown, like this meta-analysis, that even diabetes resolution is better. 28 studies with a longer biliopancreatic limb. And last year, ASMBS put out a review of limb length that I was fortunate to be involved in doing. And currently, there's no consensus on optimal limb length in the bariatric community. Surgeons in the US tend to make a shorter biliopancreatic limb compared to international surgeons. And it's clear that the longer you make your BP limb, you'd have better outcomes. But if you don't shorten the Roux limb, you might end up with better weight loss, but at the expense of worse nutritional deficiency. So better weight loss, better diabetes control, but at the expense of nutritional and micro and macronutrient deficiency. Now, the reasons why a longer biliopancreatic limb leads to more weight loss is unknown, and maybe I'll explore one idea, but there are other ideas that are described in the literature. What's known is that a longer biliopancreatic limb leads to more bile acids in the systemic circulation. This is a very small human study where they compared different BP limb length, shorter in Roux, longer in one anastomosis, to no bypass, like sleeve gastrectomy in 26 patients. And they measured weight loss, insulin resistance, but they also measured systemic bile acids at day 0, day 4, and 3 months later. What they found was BMI, as you expect, is best loss in OAGB, insulin resistance, and A1C best in OAGB, followed by Roux, least in sleeve. But they found that in sleeve gastrectomy, the level of concentration of bile acids doesn't change, while it changes a little bit in Roux and changes the most in OAGB, correlating with this longer biliopancreatic limb. What we know is that a longer biliopancreatic limb leads to distal delivery of nutrients, but there are others like Francois Patou who think that a longer biliopancreatic limb is a piece of bowel that does not get any nutrition because there's no food going through it, and it takes glucose from the circulation, and maybe that's why people lose weight. So it's important not to get carried away and lengthen the biliopancreatic limb without a thought process. We've done a systematic review with one of our fellows, Alice Wong, several years ago, and have determined that in type 1 distalization, you need at least a total alimentary limb length of 400 centimeters, maybe 200 to 300 of it should be common channel. And I want to share with you that in the review that ASMBS put in, similar findings are outlined. Best distalization is type 1, but if you do it, you need to do aggressive vitamin supplementation. You need to make sure there's at least 400 centimeters of total alimentary limb length and maybe a common channel of 300. And if you look at the history of distalization, you will notice that when the common channel was 50, it led to 100% protein calorie malnutrition in 5 patients, 150, 43.7%. And Higa's group did the largest study with 400 to 450 total alimentary limb length with a protein calorie malnutrition of about 21%. So if we know that we do a common channel of 300 for one anastomosis gastric bypass, 250 for DS, and maybe 400 for Roux. We could probably guess in between what you need if you do a one anastomosis gastric bypass. So when you do one anastomosis gastric bypass, you need to test your assumption and measure the common channel. And studies have looked at the common channel in Roux gastric bypass. And in this study, nutritional deficiencies are more common when the common channel is shorter. And I want to share with you one last study from Norway, where they looked at 3 groups of patients. First group with a shorter BPLM, and second and third group with a longer BPLM. So schematically, group 1, short BPLM, group 2 and 3, longer BPLM of same length, but group 2 has a shorter common channel. What they found was that the weight loss is best when the biliopancreatic limb is longer, but the nutritional deficiencies are the highest in group 2 when the common channel is shorter. So best weight loss with a longer biliopancreatic limb, worse nutritional outcomes with a shorter common channel. So it is important that we notice that whenever we do procedures that has a longer biliopancreatic limb, we are in effect shortening the common channel, and that may lead to nutritional deficiencies. And it's important to notice that our procedures are neither restrictive or malabsorptive. They work through a complex mechanism that has in its effect, or at its principle, faster delivery of nutrients to the distal L cells, which has a complex mechanism that leads to weight loss and improvement in diabetes resolution. Finally, I just want to share with you that the size of the pouch matters. The Scandinavian registry showed that you need to have a pouch that may be not more than 3 cartridges to minimize marginal ulcer in more than 14,000 patients. The longer you make the pouch by 10 millimeter, increase the risk by 14%. We've done studies to show how to make the pouches, and this is a very short video that shows that you need to measure and you need to use the cartridge length to do your pouch, and should not be more than 3 cartridges. If the pouch takes you more than 3 cartridges, you need to re-examine your technique. And systematic reviews have shown that the pouch size not only correlates with marginal ulcer, but a larger pouch is associated with lower weight loss and poor diabetes outcomes. The same could not be said about the anastomosis. And this very elegant study from Brazil showed using scintigraphy and CT volumetry that a smaller pouch has better emptying, maybe better distal delivery of nutrients. And we've shown that you could correlate the pouch size with the rate of someone developing marginal ulcer. Larger pouch, more marginal ulcer using CT volumetry. And the marginal ulcer rate clearly correlates not only with pouch size, but also with technique. So in conclusion, patients feel restriction because of metabolic mechanisms, not because you made the stomach smaller. That's why they feel restriction after type 1 distalization, even if you do not touch their pouch. They feel restriction after SADI, after sleeve gastrectomy done previously, even if you don't touch the sleeve. If you distalize Roux gastric bypass, you need to test your assumption, make sure the total alimentary limb length is 400 centimeters. Roux gastric bypass is a technical procedure with a steep learning curve, and many of the technical complications could be avoided. The small bowel length is variable. You need to make sure, even if you do the same bowel length, that you're testing your assumption in Roux about the common channel. We do a rule limb of 100, and then we try to make sure we close all mesenteric defects. The size of the pouch matter. Make sure your pouch is not more than 3 stapler cartridge length. And you need to notice that the biliopancreatic limb is longer in OHGB, DS, SADI, and type 1 distalization. Maybe that's why they're effective. And Roux gastric bypass may not be the best effective procedure for patients with BMI over 50. I didn't have time to cover that component, but this is something that's important. So procedure selection is paramount. So I want to thank again Mohit Bandari for the opportunity, and I'll be happy to answer any questions. Thank you very much.